Good evening, and let's get started for today. So in the first question, fairly straightforward one, because orthopedics is all about names and fractures. उसमें रट्टाफिकेशन ज़्यादा है as compared to theoretical concepts. So it's like a very scoring subject. So for the first question, this patient was like this is guy is a criminal. He's running from the police and he jumped from the first floor. तो अब first floor से अगर कोई jump मारेगा तो then there is bound to be injuries in this patient in the lower extremities. So let us look at the X-ray of this patient. When you look at the X-ray, you can easily identify the tibia, this is fibula, and then in the fibula, you can see one fracture present here. You can also see a fracture with respect to the lateral malleolus. You can also see a fracture with respect to the medial malleolus of the patient, because anyway, if the fibula will be fractured, then there would be a displacement of the medial malleolus of the person also. So he says, which of the following is correct with respect to this particular patient? Well, the option cannot be option number A, because you are anyway aware that sharp march fracture would be seen in soldiers. Now there he will be saying that these guys were doing marching, that is in Hindi we call it kadam tal, and when they're doing that marching and they're wearing those heavy duty military boots, then you could be having a fracture of the shaft of the second metatarsal. So I'll just write that and rule out other options as well, so that other options also get practiced. Shaft of the second metatarsal in a soldier while practicing parade can result in march fracture. In Jones fracture, it is actually the base of the fifth metatarsal. So as such, two options can easily be ruled out. So either you're left with lover's fracture. In lover's fracture, it is like, this guy went to meet his girlfriend and the girlfriend's father came and therefore he had to jump from the first floor. So in those cases, the fracture will be involving the calcaneum of the patient. But in this particular case, you can see that the fracture is not in the calcaneum, but it's actually involving the lateral malleolus as well as the fibula, and the lower end of the fibula, if it is fractured, then bound to cause displacement of the medial malleolus also. So the correct answer to question number 1 is option number D, that is Potts fracture. What is Potts fracture? It is a bimalleolar fracture. And apart from this bimalleolar, you can also be having a displacement of the fibula, the lower end of the fibula primarily present. So I think you were able to figure out the answer for this question, which is option number D. And I think a common mistake when I was checking at the back end, a lot of people made was ki, like, because they read about jumping from the first floor, they blindly answered this as lover's fracture. But as I explained to you, the lover's fracture will be having fracture of the calcaneum, whereas in this particular case, when he would have fallen, no, the foot would have got twisted also. So there is a fracture that is occurring at this point of time. And in fact, in anatomy in FMG exam, there was a similar kind of question that was with respect to a tear in the ligament. So that tear in the ligament question I'll be discussing subsequently with you. Options for okay, I'll say the answer also. That is basically the damage to the deltoid ligament. But then the deltoid ligament and the spring ligament are two important ligaments in the foot that they always put up talking about fractures. So I thought I should first introduce this question, and the answer to this question is option number D. So we move on to the second one, and I think that you would have been able to get it correct, though at the back end I saw most guys were having some kind of mistakes with respect to the first question. But that's okay. Whenever we start doing some tests, the shuru wale questions can go wrong. But then overall, like, our average performance should balance out by the second or third question. So we next talk about Trendelenburg gait, hot favorite of FMG examiner. They always put up questions on this. So while I'm waiting for your answers, I'll explain Trendelenburg gait. You see, if I ask a normal person to stand on one leg, so I will be calling this leg जिस पे आप वजन डाल के खड़े हो, the leg on which you are standing, I ask you to stand on your one foot. So the leg on which you're putting your weight will be called as the stance leg. Now I want to put attention to this particular muscle. This is by the name of gluteus medius, not gluteus maximum. So I'm talking about gluteus medius and minimus, which are the abductors of the hip, and these muscles will contract, and the contraction of these muscles will prevent the fall of the pelvis on this particular side. You can see that I have asked my patient to raise the foot off the ground on where I'm putting the star mark. The patient is raising the foot off the ground, so all the weight of the body is falling on the stance leg. Now, to prevent the fall of the pelvis on this particular side, the muscles of the opposite side where I've done the blue marking will be contracting. The name of the muscles are gluteus medius and minimus. Now, unfortunately, if a person is having injury to the superior gluteal nerve, then these muscles will become weak and therefore there would be a sag of the pelvis. The sag of the pelvis, however, will be a contralateral sag. As you can see, the pelvis on that particular side will begin to then sag down when the patient is being made to stand on the stance leg. So step number one is that whenever he will ask you about Trendelenburg gait, you should be knowing that it is the superior gluteal nerve, the abductors of the hip like gluteus medius and minimus are involved, and the sag occurs to the contralateral side. And now let us read the options. He says which of the following is correct about Trendelenburg gait. So pelvis drop on the affected side. This is a wrong statement because pelvis का जो drop हो रहा है वो तो contralateral side पे हो रहा है ना. So this is a wrong statement. Damage to the inferior gluteal nerve तो आपने solve कर ही लिया होगा. It was damage to the superior gluteus nerve. And what is the muscle that is involved here? Gluteus medius and minimus. तो maximus तो involved होता नहीं है ना. So therefore three options are wrong and therefore there is a lurch to the affected side. The moment I say this, the query of students is, sir, आप तो बोले थे sag of the pelvis. तो भाई sag of the pelvis will cause a shift of the center of gravity. When the pelvis will sag to one side, it will cause a shift of the center of gravity. So the patient to counterbalance this sag will lurch on the other side. ये जब चलेगा तो एक साइड पे ऐसे टर्न करता रहेगा, एक साइड पे ऐसे लर्च करता रहेगा. सो पेशेंट विल बी हैविंग लर्चिंग ऑन द सेम साइड. यू कैन सी दैट दिस लर्चिंग इज अकरिंग. व्हाई? बिकॉज द पर्सन इज ट्राइंग टू मेंटेन द सीजी, दैट इज द सेंट्रल ऑफ द ग्रेविटी. आई विल राइट दिस वंस अगेन. what you need to remember for Trendelenburg gait is that the sag of the pelvis is to the contralateral side. अब वो आपके एग्जाम में इसके लास्ट टाइम में पूछ ही चुका है. तो उसने अब नए क्वेश्चंस में क्या पूछा? उसने पूछा लर्च किस साइड पे होता है. सो लर्चिंग इज सीन ऑन द सेम साइड एंड द सैगिंग ऑफ द पेल्विस इज ऑन द ऑपोजिट साइड. आपको इसको निमोनिक से नहीं करना, शॉर्टकट जो है उससे नहीं करना, आपको लॉजिक से करना है. लेट्स डू दिस अगेन. लेट्स इन्वेस्ट 30 seconds into understanding. In a normal individual like you and me, when we will stand, if I focus on this particular diagram, this is for a normal person, then the sag of the pelvis is prevented by the contraction of the muscle. If the muscle is weak, then the pelvis sags on the opposite side, as you can see in the line diagram. Now to maintain the CG क्या होता है? Center of gravity. Center of gravity को maintain करने के लिए the body will exhibit a lurch on the same side, जिस side पे weakness present है. This is the muscle that is weak, so the lurch will be on the same side but sagging of the pelvis on the opposite side. So the answer to this question is option number A. I hope you were able to figure this out on the basis of exclusion, because most questions in FMG exam nowadays are not based on direct facts. Even in orthopedics, वो अभी क्या कर रहा है? He is putting analytical kind of questions. So not a difficult one, I would say, but in 1 minute time when you get, there is a bit of paucity of time, so that is where errors can happen. But with this practice on this test series, the objective of doing this test series is that you are able to get to the correct answer in the shortest possible time frame. So my suggestion to you would be, take a picture of this. Anyway, you get a PDF, but then you should keep a picture of this and this should remain on your table for next 2-3 days, so that kabhi bhi in your life, if they give you a question on Trendelenburg gait, you never make a mistake. The learning points are: pelvis sags on the opposite side due to weakness of gluteus medius and minimus, but the lurch occurs on the ipsilateral side to maintain the CG, that is the center of gravity. So answer to question number 2 is option number A, and we move to the third one for today. He says which of the following is not correct? The word is not correct about avascular necrosis sites. सो कई बोन्स में तो एवास्कुलर नेक्रोसिस के चांसेस बहुत ज़्यादा हाई होते हैं, जैसे कि प्रॉक्सिमल स्केफोइड. जो स्केफोइड का ब्लड सप्लाई होता है, दैट बेसिकली कम्स फ्रॉम डिस्टल टू प्रॉक्सिमल. When the blood supply comes from the distal to proximal, what happens is that if the bone is fractured, like if I just crudely show scaphoid bone like this, then Yep, Adil, you were right on this one. Lurch matlab he'll turn to one side. No, ऐसे लंगड़ा के जैसे लंगड़ा you understand in Hindi, that's considered to be a derogatory term, but then the person will do like this activity. That is the meaning of the word lurch. Okay, so this, let me say, is the scaphoid bone. Then the blood supply is coming like this from the distal to the proximal part. Now, if you're having a fracture at this particular area, unfortunately, the patient had a fracture at this particular area, then you can see that the blood supply of the proximal part will get affected. The distal part, the fracture occurred in this is the fracture. So unfortunately, the proximal part of the scaphoid will undergo avascular necrosis. Body of the talus also is very, very vulnerable. And then is option between lunate and the neck of the femur. By lunate ka to pade na, which is called as keen box, keen box lesion that contributes to involvement of the lunate. And the answer is option number A, guys. It is the neck of the femur. Why that is answer is because you are aware that avascular necrosis occurs in the head of the femur. बच्चे, the answer is not option number D for question number 3. आप ध्यान से पढ़ो. The answer is neck of the femur, because what undergoes avascular necrosis is not the neck. It is the head of the femur that undergoes avascular necrosis, like if there's a tumor or patient is taking steroids. So answer to question number 3 is option number A. And I would like to reiterate once again, अभी तो बहुत cases बढ़ गए हैं avascular necrosis of the head of the femur के, because at COVID time we had given steroids ना. We had given the Daba methylprednisolone to our patients. So obviously avascular necrosis, one of the important causes, happens to be idiopathic, but then it can be steroids, it can be sickle cell anemia. And sickle cell anemia, it can be like sickling crisis where the blood supply of the head of the femur can get compromised. And then obviously there can be tumors like pigmented villonodular synovitis. Idiopathic is overall the most common cause. Then the pediatric cause of avascular necrosis that we'll be discussing subsequently is Perthes disease. The investigational choice for diagnosis of avascular necrosis is the MRI. And as I emphasize, it is the head of the femur that is vulnerable, not the neck of the femur. So the answer to question number 3 is option number A. What you need to be very, very careful is the wordings of the questions. So here I will call 3 as like a silly mistake. You see, if you made mistake in question number 1, then I'll say it is like careless reading. And for 2, it's analytical. तो ये गलत हो भी सकता है, नहीं भी हो सकता, चांस का बात है. So for 2, if you got it wrong, चलता है. But for 1 and 3, you are not supposed to make mistakes, because that would be called a silly mistakes. They pull down the score. So I hope with the inputs that I'm providing, you will be able to minimize your mistakes in future. Third is sorted, guys. We go to the fourth one. Very easy. Traditionally, the question comes on wrist drop. This time it is a finger drop. And finger drop would be meaning that there is the extensor muscle problem. Extensor muscle problem would mean which nerve is getting involved. It is the radial nerve that would get involved in this patient. So the answer for this patient is option number A. You can remember pin rad. It is the posterior interosseous nerve that is getting involved. So pin rad is the way to remember that the posterior interosseous nerve gets involved, the radial tunnel syndrome manifestations would occur. And in pin rad, what you get is development of finger drop sign. The word is not a wrist drop, because it would be proximal injuries of the radial nerve that would result in development of a wrist drop. But this would be a finger drop that would be happening. Then is low ulnar nerve palsy. Low ulnar nerve palsy will contribute to development of claw hand in a patient. When it comes to high ulnar nerve palsy, then also claw hand will occur, but it is a partial claw hand. The surprising thing is that whenever ulnar nerve में चोट लगती है, तो distal part injury results in more severe manifestations as compared to a proximal part injury. Normally, proximal part injury should cause more manifestations. So we also call this ulnar paradox. Ulnar paradox क्या है? That the injury should be occurring proximally to cause more severe manifestations. But with respect to ulnar nerve, if the injury is proximal, you get like, less severe manifestation in the hand as compared to a distal injury. That is a low ulnar nerve palsy. And then carpal tunnel syndrome, I'll incorporate a question on the same. Subsequently, that would be involvement of the median nerve. So answer to question number 4 is option number A. Instead of wrist drop, the question was slightly modified as a finger drop sign. The learning point is extensors related to the fingers. Extension activity related to the fingers is the one which is getting compromised here. So fourth is sorted, guys. The answer is option number A. And let's move to the fifth one. The most common nerve of the upper limb injured during surgery. Yes, guys, I think this is one of the easiest questions for today. Commonest nerve of the upper limb that is injured during surgery. When the patient is lying on the OT table, then yes, if I say anything more, the answer will become obvious, guys. So hit the comment button for this. Okay, very good. You see, when a person is lying on the OT table, just a patient is lying on the OT table, so the medial malleolus, the medial epicondyle के पीछे जो nerve जा रही होती है, that is called as the ulnar nerve. The ulnar nerve will get compressed against the OT table. So the most common nerve of the upper limb that is injured during surgery, when patients, it can be any kind of surgery. It is, don't think that this question is limited only to orthopedics. It can be any surgery. Any surgery is done, like patient lying in supine position, it can be laparotomy also. So the arm of the patient is against, like for 3-4 hours, like if it's a long surgery, even if it's like a robotic surgery. Let's say patient is undergoing a total abdominal hysterectomy, bilateral salpingo-oophorectomy. It's a robotic surgery. Surgery is taking place for 3.5 hours. So patient is lying on the OT table, and this particular part is pressing. The nerve goes piche se, behind the medial epicondyle. So this nerve can get compressed, and therefore person would develop like ulnar nerve weakness. There would be neuropraxia that is occurring. So the involvement in this particular patient would be called as a high ulnar nerve involvement. This high ulnar nerve involvement is mainly because the nerve goes behind. बाकी सारे जो nerves are, they're basically going between the muscles, so they will still be safe. But this nerve is going behind the bone. This nerve is basically going behind the bone, and therefore will be having high chances of injury. So there are two things that I want to say at this moment. One is that in leprosy, one of the common nerve sites where the nerve thickening is palpable is the ulnar nerve. You check it behind the medial epicondyle. And second, as I told you today, any kind of surgery when is being done in a patient, when he's lying supine, then the nerve is going behind the bone, and therefore it will be in contact with the OT table. So long duration, the pressure on the nerve would result in development of ulnar nerve palsy. The query a lot of students is, why can't it be radial nerve? It is also going behind the radial groove in the humerus. But पीछे triceps है ना, there is some muscle present. Here there is no muscle present, but in the triceps, like triceps is like sandwiching the pressure on the radial nerve of the patient. Same is the case for median nerve also. So because the muscles in the arms are basically preventing the pressure on the nerve while the patient is lying supine, so they are less likely to get involved. But this nerve is directly behind the bone, and there is no muscle that will kind of sandwich the effect of pressure, and therefore this is the commonest one to be involved. The answer to question number 5 is option number A. रटने का फायदा नहीं, समझ क्या करना है. I said ये bone के पीछे से जाती है because of that direct pressure against the OT table. Medial एक reason हो गया that this is going behind the bone, and second is this is pressing against the on patient जब लेटा है तो against the OT table this particular part would be pressed, so that could result in a high ulnar nerve palsy. So 5 is sorted, guys. Let's move to the sixth one. A patient falls from a recklessly driven e-rickshaw. Like lots of time you would have got down from a metro, and the first thing you notice is these e-rickshaws which are available, Newsians most of the time, and they run without a license. I mean, anybody could be driving an e-rickshaw, and they drive so recklessly that accidents happen. So unfortunately, patient fell from a e-rickshaw and he is fractured. You can see that there is a fracture of the shaft of the femur, and the fracture is occur mid shaft, so it would be near the radial groove. And since the damage is occurring near the radial groove, so we can understand that there is like radial nerve palsy, and that is why wrist drop is also shown in the figure. You can notice the characteristic wrist drop that is present. So the question says all of the following are correct about this condition except, so weakness of extensor digitorum is present. Radial nerve has sensory component also, so sensory loss on the radial side of the hand makes sense. Weakness of the extensor carpi radialis longus and brevis, yeah, they are involved. Guys, यहाँ पे ना triceps muscle is saved. Triceps muscle gets involved if there is a crutch palsy, like somebody is using those crutches. So if the nerve is compressed in the axilla, if the ulnar, if the radial nerve is compressed in the axilla, then you get triceps also getting involved, and triceps paralysis will be occurring. But the nerve supply of the triceps starts before the radial groove only, so the triceps is usually spared. The learning point for you guys is that whenever there is an injury to the radial nerve in the axilla, that is crutch palsy, that is when triceps will get involved and you will have a wrist drop present. But whenever there is going to be a fracture of the radial groove, that is the spiral groove where the radial nerve gets involved, then in those circumstances you would be having only wrist drop present in a patient. So in both of them the common thing is wrist drop. Wrist drop तो दोनों में ही है. Crutch palsy will also cause a wrist drop. Radial groove fracture will also cause a wrist drop. But the difference between the two is that the triceps muscles paralysis will be seen with respect to crutch palsy, but triceps will be spared. Triceps will be spared with respect to the fracture at the radial groove. That fundamental difference is the one that has been tested in this particular question. So answer to question number 6 is option number A. Wrist drop is a common thing with respect to whether crutch palsy or injury here, but the difference is triceps nerve supply starts much more earlier than proximal to the radial groove. So when there's a fracture of the radial groove, that nerve supplying the triceps is spared, and that is why I have written triceps sparing with respect to the second data, and for the first one triceps paralysis has been written. Answer to 6th is sorted, and Yeah, the position of the injury as you marked is gonna be responsible for this. So sixth is okay. We go to the seventh one where you can notice that there is the implant present. Like this is a surgery that has been done, right? And he says comment on the x-ray that is shown in this particular case. Yes guys, you can see this implant, very characteristic. You can see the head of the femur, then it has been, you know, hammered into the bone marrow of the femur so that it is able to hold its position. Sometimes even bone cement may be required. So he says comment on the x-rays that are shown. तो जो Birmingham hip replacement होती है, that Birmingham hip replacement will be having a round, obviously this femur head with the screw. जो BHR होता है, Birmingham hip replacement, will be having like this a round head of the femur with only a small screw that is present, and along with that there would be a acetabular cup also present. There is a acetabular cup that would be on the acetabulum side, and simultaneously there's a cup with respect to a cup kind of an appearance with respect to the head of the femur. But in this particular case, you can notice the implant is like this. It is like taking the shape of the head of the femur. Okay, let me try to recreate it once again. SA, and then it is going pointed downwards. There is no holes present in it. If you look at the second image that I'm currently showing, तो उसमें holes भी present हैं. So अगर ये holes present होते तो मैं बोलता Austin Moore. Austin Moore में O word आ रहा है. So that O वाला alphabet helps you identify that that is the Austin Moore prosthesis. But this is a total hip replacement, that is THR in this particular patient. Yeah, Ajay, you were right in your comment there. The answer to question number 7 is option number B. It is the THR, that is a total hip replacement. उसमें यहाँ पे कोई hole present नहीं होता. That holes are basically to allow the bone to grow and help in interlocking of the implant ना. When why the holes are present in Austin Moore is, again sometimes students ask me कि sir क्यों होता है hole वो. So that is allowing the bone to grow inside, and that will help in interlocking and will help in retaining the implant very well there. And for dynamic hip screw, I mean, then the dynamic hip screw will be like this. No, there would be multiple screws that would be starting from this. I'll show you the image of dynamic hip screw subsequently, but three images which are very clear at the moment is Austin Moore, which is having holes, THR implant, which does not have holes present, and the Birmingham hip replacement, which will have a screw and a acetabular cup. Answer to 7th is sorted, is option number B. We come to the 8th one. This is a IT guy. He's having this tingling and burning over the dorsolateral aspect of the right thumb for 2 weeks. He started wearing a fit. He's trying to waste your time. Now he started describing his habit of wearing a smartwatch for previous couple of weeks to monitor his health parameters. And there's a sensory loss over the base of the thumb. There's a tinel sign that is present. So there's definitely some kind of, you know, aneuralgia kind of a component present. So yes guys, what would be the most likely diagnosis for this particular patient? तो carpal tunnel syndrome तो ये नहीं है. Carpal tunnel syndrome will be having involvement of the median nerve. Carpal tunnel syndrome would be having involvement of the median nerve, and the manifestation that we'll come across there would be mainly in the form of a ape thumb, and like the description of sensory loss over the base of the thumb and tinel sign is going in favor of a radial nerve involvement in this particular case. Let me check out your answers also. Okay. This particular question is not having A as an answer because that would be median nerve involvement. और decurvens tenosynovitis, आप पेशेंट को बोलोगे ऐसे पहले फिस्ट बनाने के लिए, and then you will ask the patient to do a like a flexion, and the flexion will be causing pain in this area. Like if I keep my arm straight like this, if I do a flexion, there is a severe pain on this particular side. Or when you try to, you know, squeeze close, dry close, that is where the pain would be coming. So Finkelstein test is done for decurvens tenosynovitis. For question number 8, guys, what I wanted to remember is that the tendons that are involved in option number B are abductor pollicis longus and then extensor pollicis brevis. And the description that is given for the test, I'll show you the image for the test also, that is called as Finkelstein test. So the answer is not option number B. Avascular necrosis में तो trauma की history होगी. The answer to this is chiralgia paresthetica. What is chiralgia paresthetica? It is basically involvement of the superficial branch of the radial nerve. The superficial branch of the radial nerve is normally asked for doing a biopsy in a case of leprosy, But today, because the patient was using that wristwatch very tightly, या तो history लिखी होगी that this guy was put in handcuffs, like this guy committed some crime and the police had arrested this guy and they put very tight handcuffs, जैसे वो यूएस में अरेस्ट करते हैं हाथ पीछे करके टाइट वाले handcuffs लगा दिए. That can cause damage to the superficial branch of the radial nerve. Or it could be like a wristwatch which is very very tight, because you see all these watches like Apple Watch, Samsung Watch, you have to wear them tight, not loose, because they are gonna have sensors by which they are gonna record your vitals. So if the watch is worn very loosely, it will not be able to give recording. So that is why you have to wear it a little tight, and somebody will wear a tight wristwatch for a very long time. It will cause chiralgia paresthetica. Meralgia paresthetica is involvement of the lateral cutaneous nerve of thigh, where the patient would be having pain with respect to the anterior aspect of the thigh. But in this particular case, it is the superficial branch of the radial nerve that will get involved, and that would be chiralgia paresthetica. Option number D was ruled out because there was avascular necrosis. Decurvence tenosynovitis will describe Finkelstein test. You ask the patient to make a wrist, and then you ask the patient himself to do a flexion, ask him to move it towards the ulnar side, ulnar deviation, and there would be pain on the radial side. That is abductor pollicis levis, abductor pollicis longus, and extensor pollicis brevis are having inflammation. We call it mother's thumb, because mother has to pick up the child again and again. So ये वाला जो activity है, like you have to pick up the child, like she's a maid and she's working in like kindergarten, KG. So she has to pick up small children. So this activity again and again can result in development of decurvence tenosynovitis. So we call it mother's thumb also. And then carpal tunnel syndrome is more commonly seen in IT professionals, but there it is the median nerve and the ape thumb manifestation. But here it was very classical. What are the buzzwords in this question? Tunnel sign on pressing on the proximal to the radial styloid process. Where you feel the radial styloid process, this is where the superficial branch of the radial nerve is present. That anatomical hint that was given, no, radial styloid process, that tunnel sign का मतलब होता है tapping on the nerve causes development of pain. That was the key word that helped you understand that superficial branch of the radial is involved here, and that would be called as chiralgia paresthetica. So we are sorted for the 8th question, and this is the Finkelstein test I was talking about. Make a fist and then do a ulnar deviation. It causes severe pain on the radial side of the wrist. That's the description for Finkelstein sign for decurvence tenosynovitis. So we are sorted for a couple of other options related to the same question also. And now we come to the 9th one, where a person is coming with burning pain and tingling sensation in the sole of the foot for past 2 months. The pain is worsening after prolonged standing. That tells me that this is some kind of neurogenic cause, because if the pain is worsening on walking, then it is arterial claudication. But whenever the pain is worsening on standing, it is a neurogenic claudication. So first I have to differentiate whether I'm dealing with neurogenic or vascular claudication. Vascular claudication is a feature that is seen with Burgess disease, that is thromboangiitis obliterans. So there also the question will begin with smoker and will be having pain. The pain can be in the foot, it can be in the calf of the patient, but there the question will say pain will worsen with walking. Here it is worsening with prolonged standing. So that tells me it is neurogenic cause. Then he has himself said dorsalis pedis artery is palpable and there are no trophic changes that are noted, because if you are gonna have thromboangiitis obliterans in a patient, then dorsalis pedis artery pulsations will be absent and there might be digital gangrene developing in a patient. So I am left with neurogenic cause to be determined. जो लोग हाई हील्स वगैरह डालते हैं, जैसे कई गर्ल्स दे माइट बी वेयरिंग दो स्टिलेटोज ना हाई हील्स, तो उनको प्लांटर फेशियाइटिस हो जाता है. तो प्लांटर फेशियाइटिस तो जैसे मतलब आई वुड से शूज विच आर इल फिटिंग शूज. अगर कोई इल फिटिंग शूज डाल रहा है तो इल फिटिंग शूज डालने की वजह से प्लांटर फेशियाइटिस होता है और सोल ऑफ द फुट में पेन रहता है. तो ए ऑप्शन इसलिए बाहर हो गया क्योंकि इल फिटिंग शूज का कोई हिस्ट्री नहीं है. L5S1 radiculopathy basically means sciatica. Sciatica would mean that there would be a lot of pain in the back of the thigh, back of the calf, going into the sole of the foot, and is associated with disc prolapse, that is prolapsed intervertebral disc. So you have picked up the question very correctly, that because it is written that there is tenderness behind the medial malleolus. What is the anatomical location of the posterior tibial nerve? The anatomical location of the posterior tibial nerve is medial malleolus. It is the location just behind the medial malleolus that was given. So this is the main pickup point in the question, tenderness present in the medial malleolus, and he has himself ruled out vascular claudication. So the answer in this case is option number C, that is called as tarsal tunnel syndrome. क्विक रिकैप 15 सेकेंड्स। प्लांटर फेशियाइटिस होता है इल फिटिंग शूज की वजह से, हाई हील्ड शूज की वजह से। thromboiditis obliterans is seen with smoking, but then there would be vascular claudication where the pain will worsen on walking. And neurogenic claudication can be either C or D, but then sciatica, the location of pain is different. Here the pain will be present mostly in the back of the thigh, then will radiate to the sole of the foot, वो तो ठीक है। पर अगर वो back of the thigh से ऐसे बोलता है कि पेन जो है वो काफ में जा रही है और फिर काफ से sole of the foot में जा रही है, तो I would have thought in terms of sciatica or L5S1 radiculopathy as well, but here it is only pain in the sole of the foot, no calf, no back of the thigh. That means it is the nerve close to the medial malleolus that is getting involved, which is the posterior tibial nerve. So answer to 9th is very correctly picked up by everybody as C. We come to the 10th question for today. We'll write down the mnemonic immediately, Mugger, M-U-G-R, to identify whether it is Montegia or whether it is Galeazzi's fracture. And the hint is also there, the person fell on the outstretched arm with arm in hyperpronation. So अगर ऐसे हाथ होगा, pronated होगा, hyperpronation, and when he falls, impact होगा. So it can result in like this fracture, which is occurring on the, this is, I think everybody can pick this up. This is radius, this is ulna. So the fracture is occurring on the ulnar side, and this ulnar fracture would help me identify that the diagnosis of this particular patient is Montegia. ग्लास होल्डिंग कास्ट तो देखो एक ऑप्शन जो मेरे को बड़ी फैंसी सी लग रही है, वो तो स्केफोल्ड फ्रैक्चर के साथ में होती है, तो वो तो वैसे ही बाहर हो जाती है। और जो एरोप्लेन स्प्लिंट ऑप्शन है, एरोप्लेन स्प्लिंट इज सीन विद रिस्पेक्ट टू मैनेजमेंट ऑफ बर्न्स इन द एक्सिला, लाइक पर्सन हैड अनफॉर्चुनेटली बर्न्स इन द एक्सिला एरिया, सो वी विल बी पुटिंग दैट स्प्लिंट विच विल कीप द आर्म सेपरेटेड बिकॉज अदरवाइज देयर वुड बी मैसरेशन ऑफ द स्किन. सो एरोप्लेन स्प्लिंट. सो आई एम लेफ्ट विद टू ओनली, इधर आई डू अ क्लोज रिडक्शन, और क्लोज रिडक्शन के बाद में भी देखो क्या लिखा हुआ है, अबव एल्बो कास्ट. सो अगर किसी को चोट लगेगी अल्ला में तो फिर अबव एल्बो कास्ट तो नहीं लगाएंगे ना, तो फिर तो बिलो एल्बो कास्ट लगाएंगे. सो इन दिस पर्टिकुलर केस यू कैन सी द डिस्प्लेस्ड फ्रैक्चर विच इज प्रेजेंट. सो वील गो फॉर ORIF. ORIF वुड स्टैंड फॉर ओपन रिडक्शन एंड इंटरनल फिक्सेशन ऑफ द अल्ला. उसने खुद ही अल्ला भी लिख दिया, तो उसकी वजह से तो क्वेश्चन और भी ईजी हो गया. दैट ओपन रिडक्शन इंटरनल फिक्सेशन ऑफ अल्ला विद प्लेट एंड स्क्रूज वुड बी यूज्ड इन दिस 35-year-old person. So answer to question number 10 is option number B. Mugger is a mnemonic by which you are able to remember Montegia. The diagnosis of this patient is Montegia's fracture. As you can see, Mugger, it is the ulna which gets fractured for this particular patient, and the image of Galeazzi will come up subsequently, where it is the radius bone that will get involved. We will also study Colles fracture versus Galeazzi's fracture, but for that you need to hold on. The correct answer to question number 10 is option number B. Moving to the next one, you will notice that this girl is having a wide carrying angle, like this particular angle is substantially increased. So what I can say is that there is a deformity in the form of valgus which is occurring in this particular patient. A wide carrying angle is present. If this was present bilaterally, I would have thought in terms of Turner syndrome. Then I would have looked for like the webbing of the neck, and like if there's any information with respect to hypoplastic nipples, infantile uterus, streak ovaries, I would have thought in terms of Turner syndrome. But it's an orthopedic class, there's a valgus on one side. So yes guys, let me know, is this a gunstock deformity or is it a tardy ulnar palsy? Obviously dinner fork and garden shovel वाली जो होती है वो तो हम देखते हैं wrist joint पे. Dinner fork के भी अभी फोटो दिखाऊंगा, garden shovel भी देखेंगे, वो तो wrist पे होता है. तो either it is the gunstock deformity or it's a tardy ulnar palsy. Guys, the answer to question number 11 is option number B. Before I mark it, I want to bring to your attention two images. इसमें बाजू बाहर की तरफ जा रही है. दैट इज बिकॉज द पर्सन वॉज हैविंग अ लैटरल, there was a lateral malleolus fracture. There's a malunion because of which there's a pressure on the ulnar nerve that will cause a tardy ulnar nerve palsy in this particular patient. Tardy matlab it will occur after few years. This particular patient had a lateral lateral epicondyle fracture, and LCF fracture malunion is the reason why there would be stretching of the ulnar nerve on the medial side. जो टूटा था वो तो lateral malleolus उसका टूटा था, lateral malleolus टूटा था. This is lateral malleolus, this is medial. So lateral got injured, and then there's a malunion. So that malunion will got put pressure on the medial side, and therefore you will be having is a development of tardy ulnar nerve palsy. This is not to be confused with this very classical gunstock deformity. इन गनस्टॉक डिफॉर्मिटी दैट यू आर नोटिसिंग एट द मोमेंट, बाजू जो है वो अंदर की तरफ पे जा रही है, दैट अंदर की तरफ जो जा रही है दैट वुड बी सीन विद अ सुप्राकॉन्डाइलर फ्रैक्चर रिलेटेड टू द ह्यूमरस. इफ अ पर्सन इज हैविंग अ एससीएफ, अ सुप्राकॉन्डाइलर फ्रैक्चर ऑफ द ह्यूमरस, देन यू हैव इज अ डिफॉर्मिटी जो कि अंदर की तरफ को जाएगी, दैट इज कॉल्ड एज गनस्टॉक डिफॉर्मिटी. बट इन दिस पेशेंट, बिकॉज द deformity can be seen as that of valgus, so our answer would be given as tardy ulnar palsy. This is a common error mistake that happens. So yep, I think there were a couple of mistakes initially, then people corrected themselves. Answer to question number 11 is option number B. You have to develop a photographic memory of both of these images. Lateral malleolus fracture, lateral epicondyle, sorry, lateral epicondyle fracture. I'll write small e also here so that there is not, doesn't look like a lateral condyle. It's a chota e. Lateral epicondyle fracture that I'm talking about, malunion, results in tardy. Latin tardy का मतलब क्या होता है? After few years. Tardy ulnar palsy, because malunion की वजह से pressure would be occurring on the medial side, and that's why the ulnar would get involved. But in supracondylar fracture of the humerus, if there is a malunion, both of them, there is the manifestation is obviously because of malunion. That the implications would be either the बाजू बाहर की तरफ जा रही है या अंदर की तरफ आ रही है, so the differences would be present. And as you can see in the image now, once again the answer to the question 11 is option number beta. Tardy means after couple of years. We move to question number 12, very classical. There is a fracture of the shaft of the femur. Obviously, it's not neck of the femur here. If it's a neck of the femur, we'll do operation as soon as possible. But for like this is a traction, that is we are raising, we are using the body weight. We are using the body weight as a method of generating traction so that the bone edges would be approximated and therefore the healing will occur properly. So the word that we use for this kind of a traction where body weight itself is being used is called as gallows traction. And gallows traction is done for fracture of the shaft of the femur. Now the question would arise less than 2 years or more than 2 years. So yes guys, hit the comment button for question number 12. Yes, the correct answer is mentioned very rightly in the chat. It is fracture of the shaft of the femur less than 2 years. If it is more than 2 years, तो फिर तो वहाँ पे we'll go for ORIF only, because बच्चा भी तो movement ज़्यादा करेगा ना, so it would be difficult to keep the patient in this particular position. So in older children we go in for, or older patients we go for open reduction and internal fixation, but for like smaller kids we can go for gallows traction. So answer to 12th is option number B. Easy to identify. Next is a woman who comes with pain and swelling in the morning for past 3 days that improves with painkillers. She's saying that she's having tenderness over the distal interphalangeal joint, and the pain was starting after she was trying to tuck in a bed sheet. Like, if you have a big mattress and you're trying to tuck in a bed sheet, so unfortunately there can be a development of avulsion of the extensor tendon of the distal interphalangeal joint. You see, in this particular patient, the question is given in such a fashion that it looks like as if it's a question of rheumatoid arthritis, but there is no rheumatoid arthritis here. What is happening is mallet finger, there is a avulsion of the extensor tendon of the distal interphalangeal joint. The reason for this is patient was trying to tuck in a bed sheet ना, जैसे आप अगर अपनी fingers को ऐसे flex करके आप bed sheet को ऐसे tuck करने की कोशिश कर रहे हो, so there can be avulsion of the extensor tendon of the distal at the extensor tendon at the distal interphalangeal joint, which can result in development of mallet finger in this patient. So the answer to this particular question is option number C. In rheumatoid arthritis, history 3 days की नहीं होगी ना. I mean, if you check out the question, he's saying patient is having pain and tenderness in the morning in the fingers for past 3 days only. It improves with painkiller. That would have been okay for rheumatoid arthritis if the history was for like couple of months and years altogether. But in this case, it is for 3 days ka history, so it can't be any kind of arthritis. A trigger finger will involve only the index finger. Trigger finger, it is the A1 pulley that will get involved at the metacarpophalangeal joint, और आपको गांठ भी महसूस होगी. At the MCP joint, you will be able to feel a nodule. So trigger finger is a condition where the index finger gets involved. जैसे trigger को दबाने वाले, it is a nodule which is palpable at the metacarpophalangeal joint. Nodule palpable at the first metacarpophalangeal joint is a presentation with respect to trigger finger. So the answer in this case is the middle finger getting involved while the patient was trying to tuck in a bed sheet, and that is mallet finger. Yeps. So we sorted for 13th also, very easy to pick up on the basis of the image, and we look at 14th question now. This was patient was diving into shallow side of the swimming pool. This patient was very enthusiastic. Goa gaye, they had booked they had booked a mansion, or they had booked an apartment, big, that penthouse kind of an apartment, which was having a swimming pool. But the height of the swimming pool was only 3.5 feet. तो जो पानी में छलांग मारा तो सिर जो था, that straight away went and hit the concrete floor, and that resulted in a neck fracture in this patient. The neck fracture will be involving, as you can see, the C1 cervical vertebra, because ऊपर जो यहाँ पे दिख रहा है वो foramen magnum है. You can see a big opening here, that is foramen magnum. And then unfortunately this guy is having injury to the C1 cervical vertebra. The injury is to the arches. जहाँ पे yellow arrows डले हुए हैं, it is to the arches. So spinal cord will not be compressed, but after all it's a fracture of the C1 vertebra, a dangerous one. C1 arch is getting involved, and therefore the answer in this case would be given as Jefferman's fracture. Obviously it cannot be hangman's fracture. Hangman's fracture में तो फिर hanging का history होगा ना, judicial hanging. There would be extreme amount of extension of the neck. Hangman's fracture will be involving C2. There would be extension of the neck. Like if the question had mentioned specifically that patient underwent a judicial hanging, then I would have thought as term as hangman fracture. Clay shoveler's fracture will be involving C7. I will show you the X-ray of this subsequently. It will be seen in construction workers who are using that big wala spade to pick up the clay and throw it, and then again pick up the clay and again throw it. So there can be a lot of pressure at the back of the neck. So the muscles can result in damage to the spinous process of C7 vertebra. So the image of that will also be discussed. But C7 spinous process fracture is clay shoveler's fracture. So that is again ruled out. Odontoid fracture will be involving C2 vertebra. C2 vertebra में ऊपर एक process होता है, like the C2 vertebra has a process. That process is what is called as dens, or instead of dens it is also called as odontoid process. It helps in you to say the no movement. जैसे हम बोलते हैं ना, नो 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 नो, एक तो यस 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 होता है. If you saying no no no, then this movement occurs between C1 and C2. That movement that occurs at C2 is basically the no movement that we do. That is atlantoaxial. You see, atlanto is the first, axial is the second. So atlantoaxial joint movement A like helps us in saying saying the no, and that dens is the part which helps in saying that movement. That rotatory movement is at the level of the dens or the odontoid process. So answer to question number 14 is option number B. Even if you do not see the X-ray, you can still solve the question because of that history given. That patient is diving in water, but it is a shallow water, so the head hits directly the concrete floor, and that can put direct pressure on the C1 vertebra, and the vertebral arches will burst. So answer to 14 is option number B. When we come to the 15th question, there is a manual laborer. He's come with severe pain at the back of the neck while digging, and he also said that he felt a audible snap while he was digging, like एकदम से जोर से गर्दन में से कड़क करके आवाज आया. And then there was localized tenderness over the lower cervical spine, and then the couple of arrows which are showing that the C7 vertebra, even if I zoom into the image, you can notice that fracture that is happening at the C7 cervical vertebra spinous process. So this is gonna be called as clay shoveler's fracture, as the history itself is given. Manual laborer is given, and then you can see that at the C7 vertebra, at the spinous process, the injury is occurring. So the combination of the X-ray and at the same time the clinical history would help you in identifying this case. Let's quickly revise it. Jefferson fracture will be involving the C1 vertebra. Hangman will be involving the C2 vertebra. Cray shoveler is the C7 vertebra, and odontoid fracture is again C2, but it is with respect to the dens. It is not pars intercalaris or the arches. It is the DENS, dens, and this dens is actually derived from the notochord. In anatomy, they always ask what are the derivatives of the notochord. So one of the derivatives of the notochord is nucleus pulposus, but the second one is dens, which is present in the second cervical vertebra. So answer to 15 is option number C, based on manual laborer and C7 spinous process fracture that can be seen. And we come to 16th one. This is a postmenopausal woman. She fell down in the bathroom, she slips and she fell backward. ऐसे पीछे को गिरे. So when she fell on the outstretched hand, you can see a fracture that is happening, and this fracture is now causing a ventral angulation. जो यहाँ पे जो distal segment है, you can see the fracture very well. You can see the fracture very well, and then it is having a ventral angulation. There's a ventral angulation that is happening here. So we need to pick up whether it is a Colles fracture or whether it is a Smith's fracture. All you need to remember is the word SV. All you need to remember is the word SV. When it comes to Smith's fracture, it will be a ventral, that is a downward displacement. Like you can see, it's a ventral, मतलब आगे की तरफ, there's a ventral displacement. There is a flexion that is happening. And in this case, there's a deformity that is also given, that is beginning with alphabet C, S. S for Smith, S for the deformity which is present, that is called as a garden spade deformity. That garden spade is an instrument that's used to pick up, those patte, na, like lots of time when you have like spring season nowadays, you have a lot of leaves on the ground. So to pick up those leaves, the gardener may be using that spade to lift up. So that spade, garden spade, instead of writing the word garden spade, I'm writing a spade garden so that I can incorporate the alphabet S here. That helps you remember that it's a Smith fracture, it's a ventral flexion, and it's a spade garden deformity which can be seen in this case. Contrast this with CDE, which I described for Colles fracture. In Colles fracture, it is gonna be a dorsal displacement. It is a dorsal displacement. E tells you that there is gonna be an extension that would be present. And another thing that is present, there is a displacement which again begins, there's a deformity that happens that begins with D, that is called as dinner fork deformity. So for Colles, I think it is CDE which should be remembered, and it's very, very easy to remember. So nowadays, I think that he has stopped asking about Colles fracture and he started asking about Smith's fracture. But if you look at the information that I provided, it is very, very easy. Colles fracture begins with C. DE, that is dorsal displacement. Dorsal displacement would also be called as dorsal, मतलब ऊपर की तरफ, that would be extension. And Smith was ventral, that is नीचे. So SV was with the alphabets that I requested you to remember. Now I requested you to remember CDE, and the D alphabet can be used two times. One is for the dorsal displacement and second is for the dinner fork deformity as well. So we are sorted for two fractures. The third one that they ask you is called as Sheffier's fracture. That Sheffier's fracture is with respect to, आजकल तो देखो push button वाली cars होती हैं. So we just have to go and press on a button. Then earlier we had that ignition key वाला cars, but earlier there was a handle. That handle had to be rotated to crank the car, like a Mercedes or a BMW in Germany in 1930s, 40s. All the cars had that handle, the crank handle, and this crank handle sometimes used to spin in reverse direction, and it used to cause injury to the radial styloid process. So Sheffier's fracture is a history nowadays. It's very unlikely to get it unless and until somebody directly had impact on the styloid in the radial styloid process. I mean, nowadays, I think if somebody will come with this kind of a fracture, that would be injury from a lathi. Like this guy went for a protest at Jantar Mantar and the police wala people, they started beating up. So that's where the radial styloid process can get injured. That's a Sheffier's fracture. But otherwise, it's a little less likely to be seen. So all we have to do is in this question, remember regarding the angulations that can be seen. You can see that in Smith's fracture, which is superiorly, it is S and V, that is the ventral displacement is happening, whereas in Colles fracture, it is the dorsal displacement that is happening. So that longitudinal arrangement needs to be remembered. Easier to remember CDE, dorsal displacement, dinner fork deformity, and extensor. And for Smith, it is SV, as I said, ventral displacement that is happening. And the deformity that happens here is called as garden spade deformity. In the handout, I've also described situations. The situations are also very characteristic. Like, goalkeeper is jumping, and the way the injury is occurring, the injury is occurring in extension. That is Colles fracture, the dinner fork deformity that will occur. And here it was that typical case where a lady slept in the bathroom, and you can notice the flexion of the wrist joint that is happening, and that flexion injury is the one which is responsible for that ventral displacement also that is happening, which will be subsequently responsible for a garden spade deformity. So the kind of injuries that are given in the paper themselves help students solve the question. And if you are going to look at the x-rays also, it will become super easy. The answer to current question is option number C. And what is Barton's fracture? Then Barton's fracture is an intra-articular fracture related to the distal end of the radius. It's not a Colles fracture, guys. Barton's fracture is gonna be like intra-articular fracture. I'm writing the word IA, intra-articular fracture at the distal end of the radius. So 16th is sorted. We have talked about multiple different other varieties of fractures, and now we look at the 17th one, the very classical one. Here, there are two things that I want to bring to your attention. The first is I would once again introduce that mnemonic mugger to say that there is a fracture at the distal end of the radius. Distal radius is affected. And the second thing which is highlighted here from that circle is that there is also a dislocation of the radioulnar joint. So there are two things that are happening in this patient. distal radius and distal radio-ulnar joint dislocation is occurring. The combination of the two, you have to remember both the things, distal radius fracture and distal radio-ulnar joint dislocation, that would be called as Galeazzi's fracture. So the answer to question number 17 is option number D. Yes, Ajay, you were spot on for this one. Like mugger mnemonic had to be identified. So most of the time they ask you Montigia, Galeazzi. I tried to incorporate both of them कि वो दोनों में से कोई भी पूछे तो you are having a visual memory of the same, and therefore in the inferior slide I've tried to combine the two simultaneously so that you can check them out. In the first image, which I'm naming as 1, you can immediately see the fracture is occurring with respect to the ulna of the patient, so that would be called as Montigia's fracture, whereas the one that you can see as 2 is the Galeazzi's fracture where the radius is getting involved. So mugger as a mnemonic will help you identify and remember the facts here. Okay, as I was saying, Barton में जो injury होती है, that will be intra-articular. It is not like with respect to the distal part of the radius, that's okay, but then it's an intra-articular fracture. It can be ventral or dorsal, that's a separate issue. But then Colles fracture, Smith's fracture are totally different aspects where पूरा bone का हिस्सा टूट के dorsal और ventrally चला जाएगा, whereas a intra-articular fracture with respect to Barton's fracture. 17th is delta. Let's move to the 18th one. इलेक्ट्रिशियन गॉट अ इलेक्ट्रिक शॉक, ऐसे झटका लगा, बिजली का झटका लगा, तो ऐसे हाथ पीछे को जाएगा तो वैसे ही पोस्टीरियर डिस्लोकेशन होना है. इलेक्ट्रिक शॉक एंड एपिलेप्सी आर फीचर्स विच आर गोना बी इंडिकेटिव ऑफ posterior dislocation of the shoulder. He also got a burn on the hand. He cannot move his arm understandably. He says X-ray was done. What is not correct about this condition? So light bulb sign तो आपको identify हो ही रहा है. Then is rim sign. Rim sign means this gap will become very prominent. This gap, intra-articular gap will increase because the head of the humerus has been dislocated from its original position. So the gap between the head of the humerus and the scapula का जो labrum है, that gap will tend to increase. So rim sign and light bulb sign are features of posterior dislocation of the humerus, posterior dislocation of the shoulder. Arm is held in adduction, internal rotation, Bankart's lesion. So Bankart's lesion is what you will be getting with respect to anterior dislocation of the shoulder. The case is that of posterior dislocation of the shoulder. So the answer to this question will turn out to be option number C. In Bankart's lesion, there is a tear. That tear is present in the scapula वाला जो bone है, उसमें there is a tear in the labrum. It is what is Bankart's lesion? So the technical answer would be that it is a tear. Obviously, like it's written lesion, so it must be a tear present. But the tear is present in the anterior-inferior part of the labrum, and that is because of the anterior dislocation of the shoulder. Labrum would mean the articular edge of the scapula. But if you look at question number 18, option A, B, and D are the correct statements. Light bulb sign, rib sign, and arm held in adduction and internal rotation, all are standard features of posterior dislocation. What you mean by the word rim, R-I-M, not rin, rim sign is that there is an increased gap, there is an increased joint space, I can say like that. That increased joint space is because of the dislocation part. 18th is C. Okay, so maybe the chat was a little delayed, so I could not see comments there, but yeah, do keep commenting for each one of them. Then you can see Rafael Nadal and you can see Tiger Woods. So they always put up questions on tennis elbow and golfer's elbow. So tennis में तो they have to hit that backhand ना. So backhand जब होगा तो there would be development of the lateral epicondyle. So tennis elbow is lateral epicondylitis. Whereas when it comes to golfing, then in golfing you would have to swing at the ball. So when you swing like this, the injury can occur at the medial part. Backhand versus like the tennis backhand versus the swing of the elbow with respect to what Tiger Woods is doing, then the injury would be medial epicondyle. Try to remember at least one for today. Nadal is one of the fittest players that you ever come across. I mean, the number of Grand Slams that he has won is like unparalleled, and great stamina, I would say. And then lateral epicondylitis is something that they have to fight all their life. So answer to the question that we discussed was option number C, but then injuries of the upper limb are very frequently asked. Now is a question regarding tennis leg. So tennis leg is again seen in tennis players, and when this guy is jumping, so there can be a tear of the muscle. Now the muscle that is helpful in jumping activity is gastrocnemius. So there are two gastrocnemius inputs here. Tennis leg लिखा है तो obviously humerus तो होगा नहीं. अगर टेनिस लेग लिखा है, टेनिस एल्बो पे क्वेश्चन नहीं है, टेनिस लेग पूछ लिया वो, तो टेनिस लेग इज गोना बी लाइक इन्वॉल्वमेंट ऑफ द टीयर ऑफ द मसल इन्वॉल्व इज गैस्ट्रोनीमियस, वेदर इट्स द मीडियल. ओके, सो दो जगह पे टाइपिंग मिस्टेक हो गया, but anyway I think I can do the rectification there. It is, one is the medial head and the second is the lateral head of the gastrocnemius. I think in the app it was okay, it's just here that the options are looking the same. So it's the lateral head of gastrocnemius. It's the medial head that basically gets torn. The correct answer to question number 19 is option number A. That would be painful tear at the musculotendinous junction. This is the gastrocnemius. This is the muscle which is involved in this muscle is involved with the task of jumping only. एक तो peripheral heart होता है ना, वो soleus होता है. Both gastrocnemius and soleus are present together. So I just want to bring to your attention that the muscle that is involved in walking is the soleus muscle, and the muscle that helps you jump up is the gastrocnemius muscle, that is for explosive power. And during this jumping, there can be like a tear at the musculotendinous junction at the medial end of the gastrocnemius. So answer to 19th is option number A. Yep, Ajay, you were spot on for this one. We go to 20th. The following cast will be used for. So you can see the cast is covering the patella. It is going up to the hip joint also, but you can see that it is not immobilizing the hip joint. It is not immobilizing the ankle joint. I wanted to compare this with hip spica. जो hip spica होता है उसमें तो hip joint पूरा immobilized हो जाता है. You can see the hip joint will be totally immobilized. So this is not a hip spica, as you can see. The following cast will be used for injuries in the patella, because you don't want to limit like the hip joint flexion. Hip joint का movement आपको normal चाहिए, ankle joint का movement भी normal चाहिए, but you want to limit the knee joint का movement because the patella is injured. So this kind of a cast would be called as cylindrical cast. Cylindrical cast would be seen if a cylindrical cast will be used for management of patient who's having fracture of the patella. Answer to 20 is option number C. फ्रैक्चर ऑफ द शाफ्ट द फीमर में तो मतलब ऐसा कोई कास्ट लगाने का मतलब ही नहीं है ना, वहाँ तो हम पहले ओआरएफ करेंगे ना, ओपन रिडक्शन, इंटरनल फिक्सेशन, एंड देन विल ट्राई टू इमोबिलाइज होल ऑफ द लेग ऑफ द पेशेंट. And when it comes to fracture of the pelvis, that is where we might have to, put screws again. So like this kind of a cast would be for mainly fracture of the patella only. So like I don't think so we have to work out exclusion also here in this question. It is direct fact which can be used to remember it, but obviously not to mix it with hip spica. हिप स्पाइका कहाँ पे यूज करते हैं, तो हिप स्पाइका इज यूज्ड इन डेवलपमेंटल डिस्प्लेसिया ऑफ द हिप्स, DDH. Like this is if it's a child, so for DDH, where we use Barlow's test, Ortolani's test, I'll talk about those tests also. And then hip spica can also be used in those patients where like there's a femoral shaft fracture, maybe bilateral femoral shaft fracture has occurred and the person had to undergo open reduction and internal fixation. But the image that I showed you was a cylindrical cast. Coming to 21, you can notice Froment sign. Do not confuse this Froment sign with OK sign. That OK sign जो होता है, that OK sign is seen with injury to the anterior interosseous nerve. What you can see at the moment is Froment sign. Like you were asking this guy to hold a book. So normal person we can hold the book like this, but here because the ulnar nerve is involved, so he is trying to use flexor pollicis longus. That flexor pollicis longus is going to be supplied from the median nerve. So person, because there's a paralysis of the ulnar nerve, is trying to use the median nerve to help in holding the book here. This is called as Froment sign. Froment sign is seen with respect to injury to which nerve? Then your answer would be given as the ulnar nerve. The answer to this question is option number A. आपको थ्योरी याद करना है. थ्योरी इस तरीके से है कि जो Froment sign है, this is with respect to ulnar nerve injury. In contrast, we get a OK sign also. When I say OK, like if I say OK, very good food. So OK mein to you can be having a slight flexion. I'll show an image also. Like, we can be like, if I have to say the word OK, if you look at this image, there's a subtle difference. No, there is a subtle difference that is happening, that the person uh, is not able to do that okay, rather he's trying to pinch. No, there's this little like a pinch that is happening. So if the question is on the word okay, then you can write like this: a okay would basically mean you or help you remember that the nerve that is involved is the anterior interosseous nerve. So there's two fundamental differences which you need to remember. One, I want to say that Froment sign is due to involvement of the ulnar nerve. This is the nerve that is involved. In OK sign, it is AIN, that is anterior interosseous nerve that is involved. AOK, as I said. And then if it is posterior interosseous nerve that is involved, pin, then pin is a branch of the radial nerve. It is the radial nerve that gets involved. That would result in development of a finger drop sign, as we discussed earlier. So couple of signs which are like straightforward facts which are to be remembered: Froment sign, ulnar nerve palsy, OK sign, anterior interosseous nerve, and finger drop sign. In OK sign, what will happen is that instead of doing an OK, patient will try to replace that in the form of like a pinching action. जैसे कि pinch कर रहा है, एक हो गया OK ना, you say OK, right? That's you trying to make a round circle, and here it's literally like a pinch. Okay, so पॉट स्पाइन फ्रैक्चर नहीं, पॉट फ्रैक्चर, अच्छा वो तो पिछला वाला कमेंट था, यप. Okay, so pot spine fracture नहीं था वो, that was Pott's fracture. I think somebody commented earlier, no, that was a Pott's fracture, guys. It was not a Pott spine fracture. Pott spine is obviously TB, right? It's a Pott's fracture, that's a bimalleolar fracture. Answer to question number 21 is option number A. If they give you an image where like the person is trying to hold a credit card or a book and you can notice this flexion happening, that's because the patient is now trying to use the median nerve, क्योंकि ulnar nerve तो involve हो गई है, तो पेशेंट मीडियन नर्व को यूज कर रहा है. मीडियन नर्व से वो कौन सी मसल को यूज कर रहा है, उसको बोलते हैं फ्लेक्सर पॉलिसस लॉन्गस, एंड इज ट्राइंग टू होल्ड ऑन टू द वेट ऑफ द बुक एंड ट्राइंग टू होल्ड द बुक बिटवीन हिज हैंड्स. Answer to 21 is option number A. Must know three signs here. Froment sign, AOK, AOK, anterior interosseous nerve, which is a branch of the median nerve. And then finger drop sign that is seen with involvement of the posterior interosseous nerve, which is a branch of the radial nerve. So we are sorted for 21st. Must know. I would rate that as the most important question for today. Should not go